January 16, 1964, on this lady, Laura Shaw, an 82-year-old lady with bad heart who had gangrene, had Rutherford 5 or critical limb ischemia, which you're going to hear a lot about from Dr. Matasseri. But basically, the digits were gangrenous. And she did not want an amputation. That's all she was offered. And in fact, she ultimately got daughter to get this wire across and these Teflon catheters to dilate the SFA stenosis. Now, people and everyone in medicine, this is the nature of medicine. People are very like dogmatic, especially, oh, we can only do this, and they're not really forward thinking. But this is a field that's very innovative, very forward thinking, and it's always pushing the envelope. And so the surgeons or other medical doctors didn't really believe in it, right? And we can see how prevalent this is used now, but at that time, 60 years ago, they're like, what are you talking about? Well, so there was a profunda and an SFA. They wanted to do an endo, which we now know doesn't work, and they doddered the profunda, and that profunda stayed open. Well, we're plumbers, and the blood vessels are highway to do surgery from head to toe. Is the guy who gave a talk in Prague came to the U.S. on daughter's wishes, and he did one of the first angiographic embolizations of a GI bleeder on a cirrhotic here. You can see the gastropolic artery and how they pruned it. So again, they're constantly innovating. So again, I'm kind of a plumber of the human body. We open blockages in tubes, whether it be blood vessels, whether it removing clot from the brain, blood clots in the lungs, leg arteries, opening them up, intestinal arteries. We also stop bleeding by putting little glue or particles or coils to stop the bleeding. This is one of the famous original interventionalists, Cesar Gianturco, who developed this metal coil with these dacron fibers that he put through a catheter and stopped bleeding. This is Guglielmi, this is Fernando Buñuela, and Gary Duckweiler, who were all at UCLA, and they first used the GDC coil, which is a detachable coil. So now you have a lot more precision, and was able to do a carotid cavernous fistula in 1990. So it keeps on going. Our cancer has really blown up in the last 20 plus years, and our treatment has grown in that. And so it used to be just surgery, radiation oncology, and medical oncology, but now interventional oncology, which is VIR, has a growing role. And this started off in the 1970s, Dr. Yamada, who did one of the first transarterial embolization for liver cancer. But now we're getting all this new technology where we can freeze tumors of the kidney. We can do histotripsy, which is ultrasound kind of guided thing, a completely non-invasive. So it's all in our bailiwick and our skill set. Now, coronaries really started to take off when Mason Sones, who was a pediatric cardiologist at the Cleveland Clinic, inadvertently had his catheter enter into the coronary artery. And during that time, he did it all from a brachial cut down. Again, this is Judkins, who was daughter's kind of first fellow or first assist. And basically, Judkins was asked by Starr of the Starr Edwards Valve, who is a cardiac surgeon in Oregon Health Science, to go learn from Mason Sones how to do coronary angiography. But as an interventionalist, he's always innovating. He developed a transfemoral route, which has been used quite a bit throughout the world since. And again, daughter was not like embraced in the US, but when he went to Europe, Eberhard Ziegler and Andres Grunzig all listened with great intent to what he was saying. Sometimes the visionaries are not appreciated in their home. It's when they go out that people may listen to them, go out of their societies, go out of their country, go out of their kind of comfort zone. And so Grunzig actually took this idea that daughter had envisioned and used a balloon to open up the circulation, the coronary circulation. This was a commodity 70s. Very thoughtful physician, but again, the innovation who has if you get a chance to go down here, spindle stent. Before the balloon, sometimes it would tear the vessel, it would crack or close. He now has a scaffold to keep it open. Another guy you should read about, who's again an innovator, Amplatz, who develops a lot of devices that we use every day. Every week I use a few, we use probably 3 to 5 Amplatz plugs last week. You can plug up holes in the heart, congenital heart problems. You can snare foreign bodies out of the human body. And he also developed devices to take out stones from the kidney. Tons of innovation in our field, from Roche to Grunzig to Colapinto for tips, needles, to Maz we talked about, and a tremendous amount of innovation. You'll see Dr. Matasseri and others talk about all the tips and tricks. We have lasers, we have rotor-rooters, all the stuff you use for plumbing. Almost we have it for the human body, which is pretty crazy. And we have different scaffolds like PVC pipe equivalents to keep things open and get blood from one place to another. So there's a lot of parallels. But again, the blood vessels are a highway to do surgery from head to toe. And what's going on is we're blowing up and blossoming in what we can treat. We are one of the few surgical fields that does head to toe work. Everything's gotten super specialized. You're only doing one thing or one treatment. Here, you really have the option to treat arthritis, which I saw a couple arthritis patients treated one last week. We can do fixation of orthopedic screws and for SI joint fusions and pelvic complexity, and it's only going to grow. Men's and women's health, a lot of obstetric and urologic conditions I'm able to treat on a weekly and monthly basis and counsel patients on. Neurologic conditions, especially stroke or subdural hematomas or hemorrhage in the brain, we can help and fix. Lymphatic work, venous work, and now endoscopy. We're using scopes to do work. So you should use all those tools to help patients. Pretty exciting. Now, again, one of the key things that you have to understand is if you do not, and this is what doctor said, if you do not be a doctor, taking care of the patients, admitting the patients, and following them for life, prescribing medications, helping the patient, if you act like a traditional radiologist or a doctor who doesn't follow your patients, you won't be doing this stuff, and you shouldn't be doing this stuff. And he said that in 1968. So really, the most important evolution of our field has been embracing clinic and managing patients comprehensively. And you'll see that many of the speakers today have really endorsed that and will continue to endorse that. And if you look at one of the original ones, it was this guy, Barry Katzen, who was in Alexandria, Virginia for a while. And then he came to the Miami and developed the Miami Cardiac and Vascular Institute. And a lot of people are going to go to that meeting this weekend in Miami. It's called ISIT, International Society of Endovascular Therapy. I'll be going there tomorrow. And, he was doing open or endovascular AAAs in the 1990s. So again, very exciting stuff that was going on there. But really the key thing was he embraced clinical medicine back then. And I think that's the key. And he wrote about it and he was talked about it. And really, we need to embrace that. Otherwise, you just are not going to do the right by the patients. I was lucky enough to train under this guy, Thomas McNamara, who certainly built a lot of catheters and a great innovator. But most importantly, he was a true clinician, accepted transfers, admitted his own patients. So had a weekly clinic one day, not doing anything else, purely focused on patient care, did his own wound care. And this is me between these two great giants, Dr. Katzen and Dr. McNamara, one of the old ISA meetings where McNamara got an award. So if you want to have a sustainable practice, right? We know AI is definitely coming, but you need to understand as a clinician physician, you will get direct referrals from patients, primary care doctors, urgent care, ER, and hospitals. These are all your referrings. And so you need to take care of these patients like family. So what we realized over time that there's a lot of people who thought, oh, this is cool, but it's like lifestyle friendly, it's surgery light. That's not the case. They're dropping out or they're disservicing the patients. We are really looking for surgical minded individuals. We're either going to go general surgery, vascular surgery, neurosurgery, ortho-urology, and not afraid of the lifestyle it takes. If you like imaging, I would strongly consider doing diagnostic radiology. It has a lot of procedural aspects and you'll get that lifestyle benefit. If you're doing VIR, go all in, or your patients will be the ones that are compromised. So training, early clinic surgeries unit. And this is Andreas Adam, another great visionary, who's like, in order for us to thrive, we have to recruit from the right place. And that's why the ABMS and ABR and everyone, we've changed our pattern to recruiting for medical students. Part of the reason we're running symposiums such as this today. Again, the radiology pond is a very fundamentally different mindset. They're not patient-centric. We as interventional surgeons are focused on patient-centric thing, clinic, consults, rounding, and operating, right? You can't really you can't do both. You have to pick one or the other and do it. So our primary focus on the patient and not just procedures. You really need to understand what the patient's going through and what's best for the patient. And if you treat them like a family member, you will do that. So we really want people who love the OR, love operating, love surgery, and understand that this is a demanding lifestyle. You have to make some sacrifices. It is not a road specialty. We will learn anatomy and pathology, but you also need to know physiology, pharmacology, and microbiology. And so you have to really focus on that. Unfortunately, the residency and diagnostic historically has lacked a lot of the patient-centered stuff, diabetes management, hypertension management, counseling patients. These are things you have to learn. So you have to integrate it early and often. So that includes clinic, consults, and admissions. If you don't, you will lose that valuable skill set. And these are some of the beautiful cases of patients that I've been able to help. One was a locked-in syndrome from basilar artery thrombosis. This is early on in my career. A postpartum hemorrhage you can treat, or fibroids you can treat in an emergency situation. Complex thoracoabdominal repairs that we're able to do. You'll hear from Matt Aseri some of the stuff we could do in the pedal circulation, including now he's doing a lot of DVAs. A lot of thrombectomy. This is an older device, but we have a lot more technology that we're able to do, and some cerebrovascular kind of work as well. These are the newer devices that we're able to stent graft into the thoracoabdominal aorta. And Dr. Bott will be talking about kind of the tricuspid valve work that we're now doing, including some of the vegetation that we can remove. So really focus on the first 2 years of medical school, getting your knowledge base down. Your third year, so anatomy, pathology, physiology, pharmacology, microbiology, and study for step one. Do not take it lightly. Study hard for step one. Third year, you got to be first in, last out, and crush your surgery block. Because what we're doing is surgery. If you don't do on surgery, you don't like it or don't love it, maybe this is not the right field for you. And then IM, you got to get your heart, lung, liver, kidney, and brain down. Fourth year matters, make it count. You have to do 3 to 4 busy sub-Is, not the ones where you kind of observership. In fact, I would argue the surgery sub-I letter is the key. So vascular surgery, surgical oncology, trauma surgery, transplant surgery, something where you're actually treated like an intern. We're so new to know what we're doing as far as sub-Is. But you should not just be in the OR as a scrub tech. You really need to write the notes. You need a pre-round. You need to dedicate time consults. You should treat it like a surgical sub-I. And no need to do a DR rotation for that. Clinical integration, surgical internship. This is, again, surgery just less invasive and futuristic. So we will be doing all of this stuff as time goes on. So we have really transformed from technicians, proceduralists to comprehensive clinicians. And the first 6 letters of clinician is clinic. So if you don't have a clinic, you're kind of out. The future is far more early integration, and training is consistently continuing to evolve. And a lot of it is because the residents are wanting it, right? So we are pushing that envelope to increase it. You have to identify programs who have a growth mindset and want to transform training. If they are used to status quo, that is not a place you want to train. You want to train in a place that is avant-garde and forward-thinking at how can we transform training so when you go out, you provide the optimal interventional care to your patients and clinical care to your patients. We have to think completely outside. ICU is very critical. We do a lot of it. In the advanced programs that do a lot of ICU, the patients are the ones that benefit, the future patients. And weekly clinic, where you're seeing patients in a longitudinal fashion and managing them comprehensively. If every clinic patient goes to the OR, that is not a clinic, that's a pre-op. Someone's already made a decision, and I think that's key. This is Harut Darmenjan, who'll be talking about spinal cord stimulators, Dr. Bott about kind of intracardiac interventions, and one of my patients that they helped me with the pedal axis through axis. At the end, the Harut is debriding all the kind of dead infected necrotic tissue, and I think that's very important. Okay, we're not just plumbers. You have to understand diabetes, the different options for them, and statins, and goal of low LDLs, offloading wheelchairs, wound care, all of that, and prescribing antibiotics has to be done. Again, comprehensive management and lifelong longitudinal, not a one and done. You have to follow them. And become the patient's doctor. Treat them like your family. So this is the future of surgery now. It is minimally invasive and maximally effective, and clinic is the cornerstone. Remember this, your patients and their families fight hard. So we need to train and fight harder. It is not going to be an easy path to become a doctor, to become an interventionalist, or to provide the care that it requires. You have to make sacrifices, but it's well worth it on the other end. Thank you.